Now, if you have a tumor that is predominantly affecting the liver and probably not responding well to the chemotherapy, your oncologist may have talked to you about getting an interventional radiologist to give an opinion regarding liver-directed therapy. Liver-directed therapy is a generic name that includes a basket of many tools that can be used to target tumors located in the liver. And there are three different types of liver-directed therapy that can be performed by an interventional radiologist, and they are: number one, embolization, and I'll explain to you what that is. Number two, ablation. And number three, it's a near treatment which is called radioligands. So embolization is when we put a small catheter into the arterial system and we navigate this catheter, which is a little tube, a very thin tube, all the way to the liver, and we find the vessel feeding those tumors, and then we can inject something to treat the tumor. And that will be the difference between Y90, chemoembo, or simply blend embolization. That's what we inject in that catheter, although the procedure is very similar for each of these. In the case of the Y90, we're injecting to treat the tumor are these little grains of sand that contain radioactive material called yttrium-90. Yttrium-90 emits a very powerful radiation particle that will kill any tumor located within 1 to 2 millimeters from that particle. Chemoembolization is when we inject some form of chemotherapy directly in these tumors. And that can be done two ways. The TACE, which is the traditional transarterial chemotherapy, we inject one or multiple drugs mixed with a substance called ethiodol that can be seen under X-rays. The other option is something called drug beads or drug-eluted beads. And that's when we soak some type of chemotherapy into these beads to be injected directly into the tumor. These beads are very small. They're much smaller than a millimeter, and they come in a little vial, and they are soaked with chemotherapy. And the advantage of the drug-eluted beads is they will disperse the chemo slowly, so they can treat the tumor over time with less side effects than the TACE. The third option for embolization, and it's used for tumors that are very vascular, tumors that require a lot of blood supply. So those tumors, in some instances, you don't even need to treat them with chemo or radiation. Essentially, just blocking the blood flow to these tumors will kill them. And that's when we use the blend embolization. Those are just blend beads. They're just beads without any drug that will block the blood flow to these tumors. The other liver-directed therapy that we use commonly is called ablation. Under imaging guidance, we place a needle through a tumor, and this needle is a very special needle that can actually create either heat or cold or an ice ball around the tumor and essentially destroy it. The most common ablation used in the liver is the microwave ablation, which is very powerful and can burn even very large tumors. But in some situations, we may also use cryoablation, which will essentially freeze the tumor and kill it. Histosonics has been getting some more attention, and that's a way to use ultrasound to actually destroy liver tumors. That's performed under ultrasound guidance and does not require even placement of a needle. And although it is in its early days and there is not a lot of data, it is very exciting. And the third type of liver-directed therapy very few people know about is called a radioligand. And what happens is some tumors, specifically nowadays neuroendocrine tumors, have some markers that may catch antibodies or hormones. Specifically in the case of neuroendocrine tumors, this is called dotatate. And dotatate will ligate to this tumor. It's used for imaging of the tumor, but also can be used for treatment, because nowadays we have a special medication where they bind lutetium, which is a radioactive substance, and they bind into the dotatate. And we can just essentially infuse in the IV, and this will take this radioactive substance directly to the tumor, and that can be useful. So if you have a tumor that is relatively small and is not sitting near any structures, we prefer to do ablation. It is a quick procedure, and it certainly can destroy the tumor. If a tumor is too big to be ablated or is located near structures that an ablation could harm, then our second option is the Y90. And that's because it's very effective in killing tumor and has not a lot of side effects. If the tumor is involving the entire liver or there are multiple liver lesions everywhere and it will be too dangerous to perform the Y90. So we prefer other options, including chemoembolization or blend embolization. Now, like I mentioned before, most of the time we will use chemoembolization in those cases, but some tumors that are very vascular can be treated only with blend embolization. And for patients that have neuroendocrine tumor, we always should consider the dotatate treatment. I hope this was really helpful. Thanks for joining me in another Minimally Invasive Insights with Dr. Fabio Komlos.